Thank you once again, Dr. Ndagura. So, this topic which I'll be addressing is a topic that gives us an overview of what fetal medicine is all about. We recognize that there has always been a pyramid of care. Some of you may not know it as a pyramid of care, but you all know that women, we're being told in this country and beyond our borders that they should present around 16 weeks. After presenting at 16 weeks, then they will come every month. Then after 36 weeks, they will come every week until delivery. I think this is the pyramid of care that we have known for years. But within this pyramid of care, midwives were taught a set of things to just check. To say if a woman comes, you ask them questions, is there anything bothering them? Then you measure their blood pressure, you check their urine for protein or for blood or for infection. Then you palpate their tummies and you reassure them that everything is okay. So this is what has been happening. But the problem of all this is that there has not been, let me say, well-structured pregnancy risk assessment as the woman's pregnancy goes on. So the turning of the pyramid of care is what we are advocating for, to say the pyramid of care should remove this old assumption that most complications are predicted later in pregnancy. This is why women are being brought every week after 36 weeks. Because the assumption is pregnancy complication would then appear between 36 and 40 weeks. So that is why care would concentrate right at the base of the pyramid, as you will see in my next slide. But the new proposition, it's new in our zone here, in our country, because we still have a lot of women who book late. I think only 20% of our women book before 16 weeks. Because we still have lots of women who book late. We are saying instead of these women booking late, they should book between 11 to 13 weeks plus 6 days, where they will be assessed for the pregnancy risk. After the pregnancy risk has been assessed, then their care could be individualized. So this is what we are advocating for, to say let's turn the pyramid of care so that women come early, the risk is identified, and the care is then individualized. So to turn the care from reactive late detection to early prediction and prevention is what we are advocating for. So this is the traditional pyramid, what it looks like, where you start at 12 weeks, 16, then 28, then 30, then between 36 and 41 days, women are made to come every week. This is why you see the base of the pyramid is wide, because the reviews become stitched together. So that at the end of the pregnancy, the care volume increases, but without any clinical reason why it is increasing. So why are you bringing them at 36 weeks, every week from 36, to do what? What is the individual risk of the woman that you are bringing? That was never clear. But when we turn the pyramid of care, we are saying we're going to do integrated risk assessment at 11 to 13 weeks. Then the care that follows after that will be risk directed. That means if we pick that the woman is at high risk for preeclampsia, our care is now aligned to the preeclampsia risk. We are not just saying come back, come so that we just to do your tummy and so forth. Then we will now be doing targeted surveillance. And the delivery planning will be planned and optimized. And those who are supposed to go all the way, they are told you are free to go all the way. Those who are not supposed to go all the way, they are told you can't go all the way because you have these factors that are affecting your pregnancy. So what should we do then? When women come at this 11 to 13 weeks, we suggest that we have something we call one-stop risk profiling appointment. What do we do here? When we register them, we take the woman's parameters, the age, BMI parity, medical history, obstetric history. I think you saw how we were approaching scanning women, that we're not just scanning people. We take their history first. I know there are people who scan here, who just scan people. But that's not how it works. You don't just scan people. You have to know them first. You take their history. You understand why they have come for the scan. Then we do the blood pressure. When we're doing the blood pressure, what we actually need is something which is called mean arterial pressure. This will be explained in future in presentation that will precede mine, or proceed after mine. So we do the mean arterial pressure of these women. That is 11 to 13 weeks. Then we do the scan, where we measure the CRL, the NT, the chronicity, the antenatal Dopplers, if we are dealing with twins chronicity. Then all these parameters are going to be inputted into a base model where all these figures will be converted in something we call multiples of median, and the woman's risk is calculated. Whether it be risk for aneuploidy, or a risk for preeclampsia, or risk for FGR, it is calculated. Then after it has been calculated, the woman is either commenced on aspirin, or given a follow-up care plan, or a referral, or a diagnostic procedure may be ordered. Depending if it is aneuploidy and the risk is high, we may need to offer them a diagnostic procedure. So whatever label we give to the woman, if we say you are high risk, it is not just a label that we have given to the woman. It is a care plan. Because every high-risk woman has an individualized care plan that they should follow. So that is how it works. So this is all we can screen for. We can screen for aneuploidy. Can I put a pointer there? Or it doesn't, right? Or I can duplicate, right? There's okay, sir? Okay. All right, no worries. Let me duplicate this. Right, so, right, there we are. Yeah. There is that. Right, so we can screen for aneuploidy with either combined tests or using NIPT. We can screen for fetal defects by doing an early anatomy scan at 11 to 13 weeks. We'll be talking about this later, probably in the afternoon. An early anatomy scan can be done there, and also knockout translucence associated risks. A knockout translucence above the 99th centile is not just associated with chromosome abnormalities, but it's also associated with fetal defects. So when the nuchal is way above, it's also an indication that we should look for other associated malformations on the baby. Then we can screen for preeclampsia. This will be presented in detail using MAP, uterinatal PI, PLGF, PAPA. All these markers can be done at 11 to 13 weeks. Then we can screen for FGR or placenta insufficiency. So babies who are going to be small later can be predicted at 11 to 13 week scan. And the woman can be put on aspirin and be given an individualized care plan. In addition, we can come up with the phenotype of the placenta dysfunction, because there are different phenotypes of why the placenta dysfunctions, right? We can also screen for preterm birth using history, and also once we know that the history of preterm birth is high, then they go into the preterm birth surveillance pathway. My colleague will present on that. Then we can screen them for GDM, gestational diabetes. And the care plan can be individualized. So this is the 11 to 13 weeks scan. I did not exhaust all the complications you can screen for here. Complications such as PPH, multiple pregnancy, because multiple pregnancy on its own is a pregnancy risk. They can all be screened for at the 11 to 13 week scan. So once Once the disease-specific risk has been calculated, then the individualized care plan will be given to the woman. Rather than to tell every pregnant woman that you should all come every 4 weeks, or your pregnancy is too small, come when you are 26 weeks, it doesn't work that way. The woman's care plan has to be determined by her individualized risk. So how does this risk work? We recognize that every woman, when they walk into a consult room, they have what you call a priori risk. For example, if you are 40, your risk for Down syndrome, a baby with Down syndrome, probably 1 in 40 to 1 in 60 there, just by walking into a consult room, before anybody has touched you, that is the risk of having a baby with Downs. But when you do the scan, when you do the PAPA and free beta CG, or when you do NIPT is not part of the risk, this base theorem. But when you do just the combined test on its own, the combined test will come in as likelihood ratios when you do those results, and then we are going to add to the a priori risk. So this is why a woman who walks in at 40 years, when you screen them for Downs, they may walk out of your clinic after all the tests has been done with a risk of 1 in 500. Why? Because the other tests you have done, they have lowered the likelihood ratio so much so that your risk is suddenly fallen. But a woman who walks with a risk of 1 in 40 and there's a baby who has an AVSD, absent nasal bone, reverse ductus venosus, may walk out of your clinic with a risk of 1 in 2. Because the likelihood ratio has been raised so much by these defects, which are known to be associated with trisomy 21. So this is what we are referring to say we need to add up things. The same with preeclampsia. A woman who walk in there and their risk of having repeat preeclampsia is 1 in 4 because they've had it in the past, where the recurrence risk is 25%, right? But when you check their uterine-artery Dopplers, you do the POGFs, you do the S-FLT1, the uterine-artery Dopplers are low. When you calculate their risk, they may come out of your clinic with a risk of 1 in 200 of having preeclampsia. Then you can reassure the mother that, look, this pregnancy may be safe. Instead of just telling them your risk is 1 in 4 because you've had it before. We are saying each pregnancy has to be individualized because they are what you call pregnancy-specific risks. So this is what gives us the posteriori risk. So what does it mean? What it means is that when women come to us, they already have their priori risk. Modern antenatal care means that you need to recalculate the risk so that you can give them a pregnancy-specific, individualized risk. I hope it's making sense, right? I hope so. Right. So preeclampsia is the clear proof of concept. I think I've already gone through this. That we combine all the maternal factors, the mean arterial pressure, the uterine arterial PI, the POGF, PAPA, or S-FLT1 day. Then what we predict is early preeclampsia, preterm preeclampsia, depending on what we have done. This will be presented in detail. Then term preeclampsia, and this algorithm will give us different performance at gestation. Then these women who are high risk will be put on aspirin before they are 16 weeks. Then they will be given intensified surveillance, including maternal blood pressure monitoring and fetal growth surveillance. Then the prediction of preeclampsia is very important because we know that there's a preventive strategy where women can be put on aspirin all the way up to 36 weeks, and the effect is that it reduces by more than 60% the incidence of early onset preeclampsia. That's the effect of putting them on aspirin. Then the aneuploid screening is still the same. They come at 11 to 13 weeks. We do the combined tests. We do maternal age, NT, fetal heart rate, free beta HCG, PAPA. Then we estimate the patient-specific risk for trisomy 21, 18, and 13. Then we can also do NIPT or cell-free DNA tests. I want you to know that one of the laboratories that help us with this, doing this test, I think they're out there. So during the tea break, if you have no idea of how to do it, just go and see them. They will tell you how you can do NIPT and fetal cell-free DNA test. Please don't say the people of Zimbabwe don't want it to be done. They want it to be done. They are not doing it because practitioners are not offering them the test. So cell-free DNA test is available. It can be done from 10 weeks. Then women who are high risk, we subject them to either amniocentesis or CVS, where they will need a diagnostic test to just show you the care pathway. And this is done, if we decide to do CVS, we do it before 15 weeks. If it is an amnio, it is done from 15 weeks upwards. This will allow for early diagnosis. These are some of the practical pathways with NIPT or cell-free DNA test. My colleague will probably cover this in detail. But to just show you that once the woman is high risk, we offer them CVS. If they are intermediate and they've done a combined, we may decide to offer them NIPT. Then if they are low risk, then you don't have to do anything. They come back for their normal scan. Then for the placenta dysfunction, when women come at 11 to 13 weeks, we know that there are early placentation signals that we can detect within the mother's blood. That is the PLGF and the S-FLT1, or PAPA. Normally, placenta that are likely to fail or to mature early, or that has got sparse villi, they may have a very low PAPA. The same, they may have an elevated S-FLT1 and a low placenta growth factor. So using the blood test and the uterine arteries, we can predict women whose placentas are going to mature early. Remember, the phenotypes are different. There are women who are going to develop preeclampsia with placenta insufficiency. Then there are women who are going to have placenta insufficiency without preeclampsia. And that makes up about 40%. Because when you put together women with placenta insufficiency, 60% of them will have a vascular pathology. Vascular pathology means they have preeclampsia or some hypertensive disease of some sort. The other 40%, there will be normotensive. So using the traditional methods, the obstetric traditional methods, there is no way you can predict the 40%. So this is to just highlight that the traditional method, while people celebrate it, it's one of the most inefficient way to predict babies with placenta insufficiency, because you miss 40% of them. The same with the cervix, previous history of spontaneous preterm birth, cervical surgery, late miscarriage, they all set a baseline risk. However, cervical length assessment will refine that risk further, so that you can individualize the risk to that specific pregnancy. Because if two women who have all lost babies 3 times in a trot walk in your practice, their risk based on that history is the same. But when you go on to measure their cervix, then their risk is going to differ. Because the woman with a shorter cervix is going to have a higher risk than the woman with a longer cervix. So this is what we mean by individualizing the risk. To say they cannot all be told the same thing. They can't all be the same. That is all we are saying. And they have to be differentiated using this test. Then after all that is done, of course, there's action, which is progesterone. This will be presented in detail by the team. Then, so turning the pyramid of care is not just one scan only. You will see, as more and more presentations unfold during the day, that once the risk has been identified, there's need for follow-up, there's need for surveillance, there's need for risk reassessment. Because even women who are low risk in first trimester does not mean that when they are reassessed in second trimester, they are still low risk. They have to be reassessed again at the 20 weeks, because some defects, some abnormalities, or some risks, they have a late manifestation, hence they also show us late. So, So this is my take-home message to say the first trimester is the major risk assessment visit. It's no longer a dating scan to say we just want to date you. It doesn't work like that. The first trimester is now a risk assessment appointment. And the risk must be disease-specific and patient-specific. Like I was telling you that 2 women who have lost 3 pregnancies in a throat, when they walk into your room, their risk is the same. But when they leave your room, they should not leave your room with the same risk. They should be assessed using their individual factors for their individualized risk. And then their care plan has to be different. So prediction must lead to prevention, surveillance, or a referral if you are working at a low-level center. Then there's need for quality assurance. That is, whatever work you are doing, if you are scanning, seek to have your images submitted for audit so that you know you are scanning the right way. As a country, we can localize these models. We're already doing it in the fetal medicine units. And I want to encourage even the Blawe team, as you used to try to set up, that you should use this kind of standards and set the high standards for yourselves. Because you rather aim for the clouds, so that when you fail to reach the clouds, you fall on top of Mount Kilimanjaro, right? Not to fall or to the bottom of the sea, right? Right. Thank you so much. That's the end of my presentation.